It's good, Juliet.
Thank you. Welcome everyone to our 6th session in the series of fictional COVID cases in mental health settings. I'm Juliet Brown, I'm a consultant psychiatrist in Newham. I'm joined again by the incredible psychiatry registrars who are leading on this teaching, Dr. Kate Bailey and Lindsay McAlpine. The session is for all our junior doctors, for staff grades and consultants, and we welcome again colleagues from North East London, West London, Norfolk and Suffolk, and this week also medical students from Barts and London. The format remains the same, so it's an interactive case study. We welcome your comments in the chat box. Please do copy your comments to all attendees if you want everyone to be able to see. The session is recorded, so ELFT staff can access it on the MedEd website. For everyone else, the slides will be freely available on the ELFT MedEd Twitter. The session will end at 3 o'clock as usual, and we'll hear a little bit from Dr. Gululi towards the end. Again, this case study is intended as a starting point, so we do welcome your questions and comments. This week is a little bit different. We'll be talking about the effect of the pandemic on the mental health of doctors. So please do be aware that the case may affect you rather differently than our previous cases. Next week, May the 6th afternoon, the wonderful MedEd team will be bringing us the first entirely remote Barts academic afternoon. So we won't be back with you until the following week. I just want to thank our expert reviewers for this case. Dr. Claire Gerada, MBE, former president of the Royal College of GPs and director of Practitioner Health Programme. Dr. Caroline Elton, psychologist and author of the excellent Also Human, recommended reading for all doctors and medical students. Dr. Rebecca Lawrence, a consultant psychiatrist in addictions in Edinburgh, who's written extensively on her own experience of bipolar disorder, including in a recent piece in BJ Psych Bulletin. Dr. Sandra Evans, group analyst, psychiatrist at ELFT and for the Doc Health Organisation. Dr. Bessie Venables, consultant psychiatrist and psychotherapist at ELFT. Dr. Kelly Gordon, psychologist with the liaison service at the Royal London. And Dr. Caroline Walker, a psychiatrist who blogs and speaks as the Joyful Doctor. And again, thank you to Kate and Lindsay for putting so much time, energy and general brilliance into these cases. I'll hand you over to Kate.
Hi. Hi. All right, back again for week 6. Here we go. So as usual, we're just going to start with a couple of updates from things we've talked about previously, starting off with some of the stuff we discussed last week about VTE risk in patients with COVID-19. So there's been more evidence coming out, and it's pretty consistent with what we said last week. So there's a growing body of evidence that COVID-19 is causing a hypercoagulable state, which is leading to an increased risk of PEs and DIC. There's some new evidence coming out saying that we should be avoiding DOACs, so things like rivaroxaban, because of their pharmacokinetic interactions with some of the antivirals. So as previously recommended, stick with low molecular weight heparin in the first instance for anyone that requires thromboprophylaxis, and fondaparinux is a good second-line agent. We also just wanted to draw your attention to the CoroNERV study. Is that how you pronounce it?
Oh wow, I hadn't actually thought of that. CoroNERV.
CoroNERV.
Oh yeah, that's cool.
Hadn't said it out loud yet.
Good.
Yeah. So this is a really exciting study that's being done at the moment. It's a surveillance study of any neurological features or psychiatric conditions associated with coronavirus. They're looking for cases that you've seen in your own practice. And we're asking if you do come across any presentations to use the link below to report these symptoms. They don't need any patient identifiable information, and it's already got ethics approval. All right, vitamin D.
Yep. So you might have seen an email a couple of weeks ago from the Trust about vitamin D replacement, and I guess just to kind of, I suppose, highlight that, because although the number needed to treat is kind of fairly high, it's something that's actually quite a low risk thing to add into someone's treatment, and there's kind of increasing evidence that it enhances immune function and reduces the risk and severity of respiratory infections. And we know that, of course, our population is very high risk of having vitamin D deficiency. So as you probably have been doing already, but just a kind of reminder to be checking vitamin D as a routine baseline test in anyone who's admitted. And if you've had people who have been in hospital for a long time, it's worth checking their vitamin D levels again. And then you can check the kind of NICE guidance on how to replace that. There's varying protocols, so just liaise with your pharmacists about how to do that safely. And if there's kind of worries about other comorbidities, then obviously you might need to think about adjusting the dose of that, or getting further medical advice, and importantly need to check calcium after 4 weeks of treatment.
We're getting a question from Dr. Price about how many units daily. It depends on the level of deficiency, so there is some trust guidance which gives you parameters to look for and how much to prescribe based on the patient's levels. Yeah. All right,
So on to the case for this week. So once again, you are the SHO, and this time you've taken a locum evening shift in the Liaison Crisis Hub, and you've agreed to do this at quite short notice to cover a rota gap. And the PLN has notified you that there's a patient called Dr. P, who's an IT registrar who's needs to be assessed. And there was an incident in ITU today while he was trying to put a central line in. And his consultant's on the phone and has asked to speak to the doctor who's going to assess Dr. P. So you speak to Dr. S, who's the ITU consultant, Dr. P's boss, and she tells you that Dr. P is, a very highly skilled, competent registrar who's usually very confident and decisive. But she's been worried about him in the last week or so. He's been a bit distracted, seeming anxious, irritable, more hesitant than usual, and he's been staying late to review notes every night. The department at the moment is adequately staffed, but there have been a number of people who've been off sick with COVID who are starting to come back to work. She found him today in the staff room. He was kind of shaking and crying, and he said to her that he thought he might have a fever because he was feeling very hot and sweaty. And she tried to ask him more questions, but he seemed quite dismissive. She tells you that he hasn't made any mistakes. There wasn't any risk to the patient. He kind of apparently left the procedure and someone else was able to take over. So nothing bad has happened. He hasn't made any errors, but she's quite worried about him. And she wants to do whatever she can to support him. She thinks he should take some time off. And she's also notified his partner to come and meet him with his permission. So what do we think we would want to try and find out before we assess Dr. P? Send us your answers.
So we've got a lot of suggestions coming in. Some people saying that we should be looking for physical health issues, also thinking about his past psychiatric history, and whether or not he has been tested for coronavirus. And a query, an interesting query, he's not a patient but a colleague, are we allowed? Which is something we'll come on to in a minute. Several answers popping up here about whether or not he's getting adequate sleep, which is a very good point.
Yeah.
Any other thoughts? Has there been a rota change? Good question.
Yeah.
I know a lot of the acute trusts are making a lot of changes to their rotas at the moment to adapt.
Really?
Yeah, any known alcohol issues?
And some discussions about whether or not he is or he isn't a patient. Essentially, I guess at this point he's been referred to us, so he is a patient from our perspective. Yeah, so other stresses, exams, that sort of thing. Okay.
All right.
So looking on the summary care record and health information exchange, he's not on any medication and no allergies. He's got no previous mental health contacts and he's currently registered with the GP in Oxfordshire, though his home address is in London. So the next question, though, is who should be assessing Dr. P?
So a couple of people saying that if the SPR is available, then that would be good. Someone mentioning that his GP should assess him, but it does sound like this is a little more acute than something that would necessarily go to a GP in the first instance. Mm-hmm. Question about whether there are any local arrangements, occupational health as well, and a very good point that it should be someone who doesn't know him that should assess him, although that can be tricky in this sort of situation. So I suppose we think about who's physically on site, and we've got a PLM, we've got you, the SHO, and there's an SPR on call as well. And quite a range of suggestions about who should be assessing him, but generally people seem to be saying either the registrar or their consultant should be the one to do the assessment.
All right, so especially with COVID, we've also got systems varying at different sites, even about kind of who initially makes an assessment and kind of how long they spend making an assessment. And sometimes we've got sites where there's a PLN who would do a screening and then that would go straight to the SPR to avoid kind of extra exposure to the SHO. In this situation, we think probably it's not necessarily helpful for the PLN to see him because it's pretty likely that a doctor is going to need to see him. So we kind of maybe bypass that route. And I guess we agreed having a more senior opinion would be helpful. But unfortunately, as this is a real world scenario, the SPR has just got into a taxi to go and do multiple mental health act assessments at another site and is unlikely to be back this evening. So you discuss with them by phone and think about the approach. But maybe this is also a good point to think about kind of what our anxieties might be about assessing another doctor and also assessing perhaps a more senior doctor. So maybe people can share their thoughts about that.
So some people saying that you would just treat them the same as any other patient with professionalism and kindness. Yeah, a very good point that you might not feel as confident knowing he's more senior. I mean, certainly when I've been in that position, not so much doing psychiatric assessments, but as an F2 and A&E having to assess other doctors, it was absolutely terrifying going in and doing a neuro exam on a senior GP or something like that. So it can be quite intimidating having to go in and do that sort of thing. Lots of people pointing out that you do have different areas of expertise, but I think it's important to wonder about what sort of expectations you might have coming into this assessment. Some people highlighting anxiety around the consequences of your assessment and how it might impact career. And yeah, a lot of highlighting that we need to be quite sensitive in this situation. And just a reminder, if you're responding to any questions, can you select that you're replying to all panelists and attendees so that everyone can see your answers?
Okay, so I think some of this is about acknowledging our own anxieties, which are, I think, normal in response to seeing someone that we may identify with or might have something in common with or might be intimidated by and so on. So there are sort of obviously a lot of people who have made a kind of, or it's their specialty to see doctors as patients, have thought about kind of do's and don'ts when assessing and treating other doctors. This is obviously not exhaustive, but is just some kind of guidance and things to keep in mind, many of which things you've already kind of highlighted. So, you know, as someone has pointed out, it's really important to make sure that you do the kind of full, thorough history and examination as you would for anyone else, and not kind of making assumptions that someone would tell you really important things from the history, or that they, you know, that they would necessarily have a knowledge of your specialty or remember what it is that's important to tell you about their presenting symptoms. You want to allow them to be the patient and for you to kind of do the work of history as you would in any other patient. It's important that you kind of acknowledge your own anxiety, not necessarily with the patient present, but kind of be aware of how you're feeling before you go into the consultation, and kind of discuss confidentiality and the limits of confidentiality, obviously because there are responsibilities that we all have related to kind of patient safety and so on that are perhaps different for doctors than for another assessment that we're doing. We are aware that there's the potential for us to kind of very closely identify with someone's situation, but that may not be the case as well. But we need to be aware if we are identifying very closely with someone that could cause us to kind of miss things in the history or kind of make assumptions, and that's what we want to try and avoid. With any other patient, of course, you would discuss the management plan, you would leave plenty of time for that, and involving relatives is really important as well, as long as you've got consent to do so. And maintaining boundaries as well. So there's a tendency that people talk about to become perhaps more casual when they're seeing colleagues. So it's really important to kind of maintain a professional boundary and professionalism. What's next? And I think we've covered all that. But yeah, also certainly to not assume that someone has knowledge of your specialty, and just treat them as you would another person. So he's currently in A&E, but where do you think you should assess him?
All right, somewhere private where not surrounded by colleagues. So there's some suggestions about a side room or yeah, somewhere at the back of the department. Any other thoughts? I suppose it's going to vary according to local sites. But certainly our thoughts were that, you know, he was screened in A&E, he was mildly tachycardic, but he was, you know, otherwise his obs were normal. And, you know, he was generally feeling a bit run down, but nothing too concerning going on. And A&E felt that he was medically fit to be seen at the crisis hub. And they felt that that might be more appropriate given that he knows most of the staff in the emergency department. So with the patient's agreement, the PLN brings him along to the crisis hub to see you.
So I guess the key message is not the corridor is the one thing that we want to avoid, and I guess somewhere that's going to kind of take into consideration that he's probably known by a number of staff in the department. So having him kind of loitering outside the PLN office is obviously not ideal, and actually at this time someone who doesn't have COVID symptoms is going to get diverted to the crisis hub, and that actually suits us quite well because at least we can take him off site, so that's quite good. So it wouldn't be one of these sessions without discussing PPE. What PPE should you wear to see Dr. P? There's a lot of P's in there.
So yes, same PPE as any patient. So we're suggesting level 2 PPE. So the face mask, gloves, apron. Yeah, that seems to be what everyone's saying.
Yeah, basically. So we're not expecting an aerosol generating kind of situation. So just the low level PPE. So now you've finally got him into the room, you've got your PPE on. What would you actually like to ask Dr. P?
So starting at the beginning with his presenting complaint. Yeah, just the usual clarking questions, suggestions we're getting in here. Sorry. There we go. So all the usual stuff, really.
Yeah.
Some more specific question about how much time he's getting off in his rota.
Mm-hmm.
All right, shall we move on and talk about his presenting complaint then? Here we go.
So he tells you that really at the start of COVID, he felt like very energized, excited and ready to put his skills to use. But more recently, he's been feeling drained and irritable and fearful and actually quite anxious before shifts and exhausted afterwards, which isn't something that he's felt with work before. He's working really long hours, he's not sleeping well, doesn't really have time to exercise, he's eating lots of donuts. He spends his evenings on Twitter and that was a big sigh. WhatsApp group discussing the pandemic. The boundaries between work and home are very much blurred. He's kind of always thinking about COVID and kind of needing to keep himself updated with any new guidance that comes out, which is something I'm sure we can identify with. So he's having nightmares about making a mistake at work or about his own death as well. So he's waking up in the middle of the night, sweaty, breathless, fearing he's going to die. And he's got a SATS probe and a temperature monitor at home that he's using quite often. He's looked into making a will and he's checked his life insurance because he's worried about what will happen if he does die. He's kind of avoiding talking to friends, having arguments with his partner. He's feeling like friends are kind of annoying him now. It feels like every time they contact him, they're just kind of wanting to know some tales from the front line and kind of rather than really caring about how he's getting on. He feels often like he doesn't know what he's doing. He feels really overwhelmed, but because he's quite senior, everyone's kind of looking for him to answers, to make decisions. He's had to assess a number of people on the medical wards and kind of felt like he, you know, that they weren't suitable for ITU, but has really found that that's kind of distressing to be able to have to refuse care to them. He's been kind of ruminating about patients who've died and were unable to contact their families during that time. And he's feeling more than he's ever felt in his life before that he can't really say that he did his best for people. For the last week or so, he's had these thoughts of kind of wishing he could just sleep and not wake up, and he's feeling really exhausted. And he's noticed when he's been at work, he's had these kind of fleeting thoughts that if he took propofol, that he would actually just be able to get a really good night's sleep. And he's even finding himself kind of seeing the people who are intubated and ventilated and thinking, well, at least they're getting some rest. So that's how he's feeling. Today he was preparing to do this procedure and he suddenly felt really unwell. He felt quite faint, dizzy, having palpitations, felt really smothered, just felt like he wanted to get his PPE off. He couldn't stop his hands from shaking, felt really detached from his body, tunnel vision, and felt this need of just getting out and getting away. And he tore off his PPE and ran into the office, and then a nurse told him off for not doffing correctly. And his consultant found him tearful and shaking in the staff room, and he feels really embarrassed that his team saw him do this. So there's some initial thoughts coming in already.
Yeah, so regardless of someone's job or seniority in their occupation, if they're distressed and anxious and needing help, they're a patient like any other, which I think is a really, really good point. Yes, some more points about boundaries. Of course, they're coming in really quickly. Asking about who supports him best, how he relaxes, things like that. Rosanna's asking about whether he's ever had a panic attack before, which is a very good question to be asking around about now. And lots of points about burnout, about anxiety, depression, and moral injury. Some other things that people want to find out is about whether he's had any past psychiatric illnesses, whether anything like this has ever happened before. Yeah, some more suggestions coming in about panic disorders and adjustment disorders as well.
Okay. So I guess these were the kind of list of things that we came up with at the start of this. So, and I think you've kind of mentioned a lot of these: burnout, depression, panic, anxiety, adjustment, and acute kind of stress reactions, and potentially, which we haven't yet explored, is drugs and alcohol or withdrawal from these things. So what else do you need to find out? I think some people have already mentioned kind of past psychiatric history, medications. So we're getting some other comments coming in now.
Any questions about family history of psychiatric illness? You know, is he self-medicating? And some people are very concerned about his thoughts about propofol, which I think is understandable.
Yeah. Questions about rotas, level of support at home.
And questions about how the team are debriefing in ITU as well.
And very good point about whether he's actually staying with his family or whether he's staying away from them, and suicidal thoughts. Yeah. Okay, so I guess it's just everything that you've already mentioned. We said, you know, we need to have a kind of normal approach and kind of cover everything as we would normally. And I think obviously with risk, as we mentioned, there's kind of risks to self, but also we need to think about risks to others, risks to career, risks to reputation, all that sort of thing. So yeah. So he tells you that he had anxiety when he started his clinical years of medical school, and at that time he saw student services and had a short course of CBT, which he found really helpful, and he kind of got back into things quite easily, didn't need any medication, no history of self-harm. He has only ever had a shoulder dislocation when he was in medical school, otherwise very fit and well. He was born in Oxfordshire, describes a pretty sort of comfortable upbringing initially. He was quite close to his mother, but his father, who was a surgeon, was more detached, and his father ended his own life when Dr. P was 12, and it transpired after he died that he actually had a second family. His older sister is a radiologist with 3 kids, and he is kind of in touch with her kind of sporadically. When he was younger, he attended boarding school, did really well at sports, academically, and things have gone pretty kind of smoothly for him career-wise. He's doing the job that he wants to do. He married at 29, he has a male partner who's an academic GP trainee, and they have one adopted boy who's 4 years old. And they're in their own home with a large mortgage. He says he doesn't use any illicit substances. He is drinking a few beers most nights to relax, to help him sleep. He's noted that he's drinking more coffee than usual just to kind of get going in the morning, doesn't smoke, and no forensic history. So a mental state examination, he's a tall, slim white man who looks pretty tired. He does look anxious and has a kind of restricted affect, but he is able to establish rapport with you. He is a bit pressured in his speech, but kind of normal and interruptible. He describes anxieties about work, his family, his mum, his patients, his own safety. He says, that he was really fine before the pandemic started, and doesn't feel that he has a sustained low mood, but he does feel kind of on edge all the time and can't switch off. He's worrying a lot about making an error at work, also about his own health, and does think he's probably going to get COVID and worries he'll die, but he's also worried he could infect his family. And he's having these kind of images of patients who have died and them having died in distress. And he's having fleeting thoughts of not wanting to wake up, which is really this sense of kind of just sheer exhaustion, wanting something to stop. And as we mentioned, kind of at work, he describes seeing the propofol and thinking about it, but not having kind of any active plans. No abnormal perceptions. He describes poor concentration, but objectively appears to be able to kind of retain what's going on in the conversation. He does know that he's struggling. Today was a bit of a wake-up call though, so he kind of felt like he was just about coping, but is quite shocked by what's happened today. He feels like he needs a break, but he also feels like he signed up for this and he should be able to cope. So at that point, the PLN ducks her head around the door and says his partner's asked if he can join. And Dr. P says yes. So his partner comes in and says he's not going to admit it, but he had a problem with alcohol at uni, and whatever he's told you, he's probably drinking more than he's saying. So the partner then asks if he can speak to you alone, and Dr. P agrees. So what would you like to ask Dr. P's partner?
So a very good point that we should be listening to his partner first before we jump in with lots of questions. Understandably, the partner's going to be quite concerned at this point. So yeah, lots of more specific questions about his alcohol use. So how much is he drinking? Yeah, things like that. And just more generally, what are his concerns? How is he doing? And I did notice a few points popping in about who's looking after the child and whether there's any safeguarding concerns there. You'd also want to know about his pre-morbid personality and anything else? Yeah, and prescription drugs and any drug use that our patient hasn't disclosed. Yeah.
Okay. Oh God, sorry. So his partner tells you that Dr. P had been sober for 8 years, but had started drinking again recently. And this was just a kind of beer after work to wind down, but it has increased to having beer every day and some spirits. He found a kind of empty bottle of whiskey in the bin. The partner doesn't think there's been any drinking in the morning, more just late at night when he can't sleep. He was worried because he found a life insurance website open on the browser of Dr. P's computer and was quite worried that he might be suicidal, but Dr. P denied this when he asked and said more that he was worried about kind of what would happen if he died of COVID. But his partner does say that it's quite likely that Dr. P's father had alcohol dependence as well. He's quite a private man, doesn't really talk about his emotions, been a bit more irritable lately, but no kind of physical aggression. He feels a bit kind of distant from their son, but again is still kind of taking good care of him, although the partner is the primary carer at the moment, is at home working from home. So I think we should just do the formulation later.
Yeah, I think we're running a bit short of time. So we're just thinking about this formulation. What we've got is a 35-year-old doctor who's got this history of some mild alcohol use and anxiety. Anxiety and alcohol dependence. And this in the context of losing his father to suicide at quite a young age. He's presenting now with anxiety and panic attacks and with poor sleep and symptoms of adjustment disorder. And this is all happening in the context of the pandemic that we're all working in at the moment. His coping mechanism of work has been challenged by some of the realities that he's facing at the moment, losing patients, long hours, and other challenges like rota gaps. And we're seeing an emergence of some new suicidal thoughts and increasing use of alcohol over the past few weeks.
Okay, so at that point you give your SPR a call, and they suggest that you explore his risk a bit further, explore his insight into his alcohol use, and also find out kind of what he thinks would be helpful and what he needs at the moment. So you speak to him a bit more about his sort of suicidal thoughts with his partner present, and he says he hasn't kind of really talked to him about these feelings of kind of not wanting to wake up and feeling really exhausted. But he says very clearly he's not planning on doing anything. The thought about the propofol was very much kind of, he's around these drugs all the time, and he was kind of there and feeling exhausted, and he saw it and he thought, gosh, that would really put me out really well for a short time. But he doesn't, he hasn't taken anything from work. He doesn't want to. He's quite frightened of dying. He's kind of worried about dying of COVID, and the insurance kind of was wanting to make sure that his family were taken care of. He does seem to be quite relieved to be opening up about this, and he says that he would open up more to his partner, he thinks, in the future, and or a crisis line if the thoughts come back. He relapsed into drinking about 2 weeks ago. He came off a run of nights and just found he couldn't get back to sleep after that. He couldn't get his sleep-wake cycle back in order. And he started drinking a bit of beer, but then it's kind of gone to having about a tumbler of whiskey a day. And that's resulted in him drinking about 1 bottle of whiskey over the last week. He feels like he's craving when he gets home in the evenings, but he hasn't had any withdrawal symptoms. He hasn't drunk anything in the morning. He does think he could probably stop the whiskey straight away. He says he's very clear he's not using any additional substances, he's not taking any benzos or any other drug, and he agrees to have a UDS to demonstrate that. So now that he's kind of talked a bit more about what's going on, he feels kind of a mix of relief but also embarrassment about what's happened, but he is kind of reassured that his consultant was supportive. You talk about taking some time off, and he thinks, I probably do need to take some time off, but again, that's a kind of mix of relief and guilt. He does acknowledge that he needs some support with his mental health, and he would quite like to kind of take something to help him sleep, because that is a big struggle for him at the moment. So what do you guys think we should do kind of at this point? What would your management plan be? So one suggestion of signing off work, 1 vote for practitioner health program, reducing alcohol and coffee.
Some suggestions around Zopiclone as well, and time off work. But there has been sort of comments suggesting that actually taking time off work might make him feel more guilty in the current situation. So that's something that might have to be talked about. Yeah, definitely. I think it's a difficult balance, isn't it? And we'll talk a little bit about that as we go forward. Yeah. There's also some comments about occupational health, and then consideration about whether we should be thinking about Zopiclone or promethazine for his sleep.
Yeah. Okay, so the SPR also discusses with a consultant on call, and you agree that he could probably have some promethazine to help with sleep, and you think actually a HTT referral is probably appropriate, partly bearing in mind the fact that things could get worse actually if he's off work, although it doesn't seem like it's actually really safe for him to work at the moment, but I guess taking into consideration that he may become, you know, more guilty and kind of decompensate being off work. So we want to kind of monitor things because we do think he's actually quite high risk. So we want to think about kind of how he can gradually reduce his alcohol. He's going to contact his consultant in occupational health and also kind of discuss with you about what could be shared with his consultant in order to kind of keep communication lines open. And he's going to self-refer to PHP, which we're going to talk a little bit more about later. So you explain this to him, and he and his partner are quite pleased with that. They think it sounds like a decent plan. You ask if they've got any questions, and then Dr. P says, will I be reported to the GMC? What would you respond to that?
So it seems like a pretty unanimous no from everyone that's responding here. Or certainly people saying no, not at this point or not yet, which I think is probably the right answer. That's certainly what we were thinking. So the GMC does say that if you're managing your health condition and getting the right medical treatment and getting appropriate support, then your fitness to practice will not be affected. So there's no need for them to get involved at that point. But they do point out that where you've got a condition that's susceptible to relapse, you should be taking steps to ensure you can practice safely until your treatment and management have been effective for a reasonable period of time. And there's also the GMC guidance around your duty to raise concerns. We've all got a duty to raise concerns where we think patient safety or care is being compromised. I think in his case at the moment, he's identified there's a problem, he's talking to us about it, and he's got this intention to go to occupational health and speak to his consultant. At this point, I think it's probably not necessary, and that's what we'd be telling him now.
And I think just to encourage him to allow as much as possible information sharing between the people who are treating him and the people who are going to plan his return to work, because it's when there isn't good communication that things can go wrong. So he's someone that, you know, we feel like we have a good plan for, but if we were to find out that actually tomorrow he's decided to turn up to work and has decided to go against that, then that would obviously worry us a lot more, especially if he's still potentially drinking and kind of that sort of thing. So just thinking about mental health of doctors, we know that it's very common amongst doctors. That 27% of people have reported a mental health diagnosis at some point, 7% in the last year. We'll share the kind of references for this at the end of the slides. We know that the suicide rates are kind of 2 to 5%, 2 to 5 times that of the general population, and actually thoughts of suicide are higher in doctors compared to the general population. And this was obviously all kind of pre-COVID sort of rates, and we know that there are high rates of distress but low rates of help seeking, and that stigma kind of exacerbates that. Debbie Cohen, who has done a huge amount of research into kind of doctors and medical students with mental health problems, says that fewer professions stigmatise mental health disorders more prominently than medicine. Hopefully, I think the fact that we're doing something about this, but also, you know, things on Twitter and you know, there's a huge number of people speaking out more at the moment, and I think that it's slowly changing. When we think about kind of the mental health of doctors, the things related to being a doctor, and particularly complaints and GMC involvement, are often a factor in suicides. Doctors may not know where to seek help, but we do know that there's a huge number of organisations now available to help people. Of course, some of us are all too aware that the personality traits that make us good doctors also make us bad patients, and also at risk of depression and burnout. So perfectionism, obsessiveness, and Claire Gerada describes this kind of triad of guilt, low self-esteem and persistent sense of failure. And of course, fear of professional implications is also a factor in sometimes kind of avoiding care. However, doctors can also be very good patients, so they often engage well in treatment. They persist with treatment, and actually they can recover quite quickly. And we know that the experience of the first disclosure from Debbie Cohen's work is really important in how people go on to manage their health conditions and kind of be open about that in the future. So really important for trainers to be aware of that in how we respond. So a lot of things are the same though as the general population. So risk factors for suicide, depression and substance misuse, primary care is still important, stepped care is still important, continuity is still important, and involving families and that sort of thing. What is different, we've already said some of these things, there are kind of high rates of presenteeism, especially kind of during pandemics and things where people feel like they just have to kind of keep going for their colleagues. There's potentially access to high risk medications, high lethality methods. There's a load of shame and guilt and difficulty in asking for help when you're supposed to be the one who's supposed to help other people rather than get the help yourself. There's trouble getting time off for healthcare. Lots of doctors don't have GPs, partly from moving around and that sort of thing, but not getting time to go and register. And there's the, of course, fear of professional regulator complications. Do you want to take this one?
Yeah, or I could just.
Okay, sorry. So I think we're all aware that COVID-19 is going to create a huge amount of trauma, and the trauma-informed response that is described by the COVID trauma working group is really helpful in thinking about the kind of different levels of trauma. So there's kind of direct threat to healthcare staff's life, which is a kind of primary traumatic exposure. There's kind of treating severely ill people, sometimes without sufficient PPE. And then there's a kind of secondary traumatic exposure of witnessing the suffering and death of others. And for psychiatrists, there's then also kind of hearing about the suffering and death of others or these other traumatic exposures. There's a threat of personal loss and loss of family members. And we know from other pandemics that up to a third of staff will experience high levels of distress. We know that sleep is required to process memories, including traumatic memories, and that, of course, that's the thing that's disrupted at the moment. And we also know that informal support is the most helpful, but of course, social distancing can deprive people of their previous support networks. Moral injury is a term that kind of came up in there and in the comments, and Neil Greenberg has really described that during the COVID outbreak, many healthcare workers will encounter situations where they cannot say to a grieving relative, we did all we could, but only that we did the best we could with the staff and resources available, and it wasn't enough. And this is a seed of moral injury. So moral injury is essentially the psychological distress that is caused by actions or inactions which violate an individual's moral code. Originally came from soldiers, but it has been applied to healthcare professionals, and certainly is a kind of very live issue now when we're facing kind of shortages of staff and resources and so on. And it's not a mental disorder in itself, but it is a risk factor for a range of mental health problems, including PTSD and suicidality. Now, also came up in the comments, again, it's a syndrome, it's an occupational phenomenon of kind of exhaustion, cynicism and low professional efficacy, and it was related to kind of prolonged stress, job stresses, chronic emotional interpersonal stresses. Rates were kind of doctors were between 25 and 76% across different studies, and again, that was pre-COVID, so you can kind of imagine what's kind of happened since that time. Alcohol and other drugs, I think, are important to kind of continue to be aware of. I'm sure we're seeing people presenting with alcohol and drug problems, maybe people relapsing in this time. There's a lot of kind of jokes going around on Twitter about the amount of alcohol that people are drinking in lockdown. But as you know, increasingly we're seeing people talking about the kind of darker side of that and the kind of burden of addictions during the pandemic. This is an article, a blog from the BMJ, from one of the RC Psych service user representative or family representatives, which is a really kind of insightful description of dealing with addictions during COVID. Again, really important for doctors. As much as there might be a stigma about mental illness in doctors, substance misuse is a whole other level of stigma, and there's a huge amount of denial and shame and so on. And again, COVID relevant is the fact that kind of people who might have been living with families, maybe living away from their families, the temptation to drink and using alcohol to try and kind of deal with the stress is an issue. We'll just, I think, skip through this. Lindsay made it. It's so beautiful, but I'm just going to skip through it quickly. Sorry, guys. We'll share the slides. Essentially, again, the kind of trauma group have gone through a guidance for how organisations should respond in a kind of trauma-informed way to what's going on, and that is kind of, some things are really obvious, like good quality, open, accurate communication, rotating workers from higher stress to lower stress functions, buddy systems. There's a lot of evidence from that from military kind of operations. Basic needs, I think that's kind of what came out of China as well, the early kind of studies. Helping people to prepare for the potentially traumatic situations that they're going to encounter. So not kind of pretending that those things aren't going to happen, and kind of trying to help people prepare for these. Having good feedback and kind of responding to things quickly, and all of the kind of evidence is about kind of bolstering people's regular kind of ways of coping with things. So encouraging people to kind of talk to the people that they would normally talk to, but then also having formal psychological therapies if needed, if those kind of general coping strategies don't work, and continue to monitor after the crisis has settled. I think you'll probably all be aware of this, is that there isn't, evidence for psychological debriefing. Really, any sessions that make people talk about feelings if they don't really want to is unhelpful and actually potentially re-traumatizing, and same with kind of resilience training, as it has a high dropout rate and doesn't really show any benefit in reducing PTSD, and really kind of active monitoring if people are distressed, letting people have their natural coping mechanisms, but also being able to offer some psychological intervention if that's not enough. There's a lot of COVID-specific support out there for doctors and healthcare professionals. So Practitioner Health Program, which we'll talk about shortly, is offering kind of daily online support groups. Practitioner Health Program, of course. ELFT has psychological support services. Okay, finally back to the case. So you're back at work in home treatment team and you haven't slept very well and you found it hard to switch off after you're on call. You'd already done another late shift earlier in the week as a locum because of shortages. And you're on nights over the weekend and you're really dreading the sleep disruption. You're talking with Dr. P in supervision with your consultant and you look at the PHP resources together. Your consultant asks you how you're getting on and you admit that you're feeling pretty tired. Is there anything that you think could help you at the moment? Any ideas that people might have?
Sure. Some comments that the PHP resources are for us as well. And some other good suggestions about winding down before going to bed, taking some annual leave. Someone saying that they took annual leave last week, which was a very good call. I'm just back from a few days of annual leave. It was brilliant. Some people suggesting making use of your balance groups, swapping on calls to kind of lessen the burden in any particular week.
Yeah. Don't take extra shifts. Yeah, difficult. I think we all like to feel useful and like we can kind of jump in and help, but I think acknowledging our own limitations is important. So you make a plan to spend a day doing discharge summaries. I personally find that very soothing, others may not, in a separate office, and your consultant suggests you go home early to get some rest, and you agree to have a couple of days of annual leave post nights so that you can kind of get your sleep back in order, and that makes you feel a bit better. So as we said, there's a whole lot of kind of, there's COVID-specific support. There's also kind of general support, which has been around, but a lot of it has kind of been bolstered in the time of COVID. So BMA wellbeing, really important that the medical students are aware of this as well, because that's available to them. 24-hour counselling service that also offers brief counselling, and they've just announced also that they're actually offering these services to spouses, partners and dependents as well. The British Doctors and Dentists group is one that a lot of our peer reviewers suggested. It's a peer support group for doctors with addictions. Doc Health is also a psychotherapy service. The psychiatrist support service. There's almost too many resources, but I think they're all good. So it's worth we'll share the slides anyway. Specifically though, it's worth special mention for the practitioner health program. It's only been, I think this year that it's been kind of rolled out across the country. It's a really amazing service. It's free, confidential, self-referral. We've heard that they're able to see people very quickly at the moment, so they're kind of quite an amazing service. They're still operating, of course, remotely, and they're able to offer advice, consultation and case management, as well as kind of access to psychological therapies as well. And they're obviously very skilled at negotiating issues if people have got GMC or kind of performance problems as well. So finally, you've had your few days of leave, feeling ready to go again, you're back at work, and you look up what's happened with Dr. P, and he's been engaging really well. Your consultant saw him on Monday. He was doing okay. He's trying to cut down his alcohol, and he's found the promethazine quite helpful. He's contacted his GP. He's been given a sick note for 2 weeks. He's managed to register with a GP locally. He's notified occupational health, and he's been contacted by PHP, and he's had a kind of online assessment and has been taken on by their service. So he's coming in to see you and your consultant at the crisis hub. He's finding he's sleeping better. He's reduced his drinking to 1 beer on alternate nights. He does feel tempted to drink all the time, especially because he's at home. He feels kind of the craving is still there. He's making a really conscious effort not to read Twitter, and he's trying to kind of watch films, play with his son, kind of have quite clear boundaries between work and home. He managed to find one of the online support groups via PHP, and he was speaking to other doctors who were away from work, which he found quite reassuring because some of the emotions were kind of similar to how he was feeling. And he also met some people who were recovering from addictions. He hasn't had any further suicidal thoughts since being seen in A&E, but he did kind of have a bit of a sort of period of distress when he heard the clap for the NHS on the Thursday night, because he felt just really useless and like he's abandoned his colleagues. And he wants to start to return to work, but he also feels frightened about making a mistake. He still feels like his head isn't quite in the game, his concentration is still quite poor. And he's planning to speak to occupational health next week, make a plan for graded return in consultation with PHP. So we made it through. So essentially the key points, I think you probably know this already, but doctors are at a kind of high risk of burnout, trauma and moral injury, and there's going to be a lot more of that, especially during COVID-19. There's a whole load of kind of losses that I think we won't come to terms with until after this has settled down a bit. Doctors are at higher risk of mental illness and suicide, but actually they can do really well with treatment and can engage really well. It's normal to feel anxious when we assess fellow health professionals, and there's a whole load of reasons for that. So do kind of seek support with that as well. And there's a lot of sources of support which have always been there, but many of them have been boosted since COVID. So there's a lot of kind of ways of getting support out there. And I think, as an organisation, our response to distress and disturbance does need to be proportionate. There's really good evidence for kind of low level, all of the things that we normally do, chatting to colleagues and that sort of thing. But there also needs to be kind of specialist psychological therapies available for those who need them as well. Right. There's a whole load of resources which we will circulate as well. And this is the book in case, I don't know if now is actually the right time to read it. Maybe, yeah, I don't know, see what you guys think. I think it's fantastic, but it sort of is also quite a difficult read. And here are some links to some of the articles from our peer reviewers. So many thanks to our peer reviewers as well. We had fantastic responses to this one. And that's it. Sorry.
Okay. Thanks so much, guys. Yeah, really lot in that case. Lots of resources. Hopefully everyone will find that helpful. And obviously, there's a lot of support at ELFT as well. Hopefully you will know that and you'll find that if you need it. We're just going to hand over to Dr. Gillooly for a few minutes. Sharman, if you could unmute Dr. Gillooly. I think you want.
Okay, I've unmuted. So thank you again, folks. I thought that was fantastic. It was really, really well presented, and thanks for all the research you've done into the background of that. And it's something that's certainly in my mind at the minute. A couple of things just for me to mention that's going on within the trust and the executive. Firstly, it's to talk a little bit about you've noticed in the national press about BAME, NHS staff, and the disproportionate poor outcomes that BAME NHS staff are having, in particular in that the doctors actually. And I think last week when we looked, all the doctors, NHS doctors who died from COVID-related illnesses were all BAME doctors. So very, very worrying. Nationally, there's been a task force that's been set up to look into the reasons for this. And Navina is sitting on that task force, so we'll get some input into that task force. As well as that, on a local level, Lynn Sanduza, the chief nurse, and Edwin Ndlovu, the director of operations, held a BAME staff network meeting on Monday, which almost 200 people attended. A virtual meeting, of course, just to speak to BAME staff and get an idea from them about ideas that they think would be useful for us to do. Lorraine and Edwin are feeding back to the exec next week, and Amar Shah, the Chief Quality Officer, and Tanya Carter, the Director of People and Culture, will be developing a trust response for BAME staff and how we can help support BAME staff during the pandemic itself. So a lot of work in that, and I think we have to see how things develop as we move along. The other thing that I wanted just to mention that we're doing a lot of work on just now is thinking about how we move forward and how we shape our future services as we move towards the lockdown being reduced. And I think with that in mind, the thing that keeps coming up that I'm hearing the whole time is the concern about the mental health surge as the lockdown is reduced. That mental health surge really is thinking about our service users who we don't have much good contact with at the minute, who we've only got virtual contact with, and finding a lot more mental health problems as we gain that contact back, and how we got to manage and cope with that surge in demand for our services. But I think apart from that, it's not just our service users we've got to think about, it's also the population that we serve we've got to think about. You know, people are going through at the minute really traumatic experiences secondary to COVID, and we're seeing that come up a bit in our crisis lines as well. And as we move forward, I think we're going to see a big demand in mental health services from the general population, bigger than what with the demand we'd had before. We have to think about how we foolproof in that as well. Lastly, and that brings us back in the whole circle, we have to don't forget our staff and our staff's mental health needs. A lot of staff have been working full out for the past 4 or 5 weeks. And, you know, I think eventually what we will see if we don't watch is their staff burning out, exactly like this case has shown. And many staff being traumatised by what they're seeing and the experiences that they're having. So we have to think as well, we've got the team, I think, have given you lots of pointers of what support services are there. But how do we join them all up, and how do we make sure our staff are safe? So that's all from me. Just lastly to say thank you to everybody. I know it's really tough at the moment. I think the pointer you were given at the end was a really important thing. Make sure you take care of yourself. Self-care is really important. You're really important to us, so you need to take care of yourself so you can provide that good quality care. And take care. Have a good week.
Yeah. Thanks, Paul. Really helpful to have you with us again. Thanks, everyone. We're going to end it. We're going to end now, so you can all get to whatever your next sessions are.
Balance group.
Dead on 3 o'clock.
And just a reminder that we're not here next week because of the Barts afternoon, but we'll be back the following week with more COVID cases.
Yeah. Thanks.
All right.
Thanks, everyone.
Bye.
Bye.